Swanson, Heather Swanson. The first part of my testimony will be on behalf of the Nebraska affiliate of American College of Nurse Midwives, and the second half will be on my own behalf. Submitting a letter from one of our CNM members, Heather Ramsey, who's unable to make it today. She's the owner of the birth center in Bellevue, and also her consulting physician, Dr. Finley, submitted a letter. He was unable to come as well, so those letters are from them. The American College of Nurse Midwives, I believe you guys received a letter from our national office in support of this bill. Our state affiliate is also in support of it. This is something that is a standard of care across the U.S. for nurse midwives to be a part of. Now, a majority of nurse midwives elect to practice in the traditional settings of clinics and attend births in the hospital. A small percentage of births in the U.S. are out of hospital, about 5%. About 1% of midwives attend home births. Internationally, though, a large majority of the care in developed countries that pay less per capita for maternal health care, and where in those countries there's a lower maternal and infant mortality rate, most of the care is being provided by midwives. And the U.S. model of midwifery care for certified nurse midwives is modeled after the English model, where CNMs are trained in nursing and midwifery. Of course, there's a different type of midwives, and this bill is not about direct entry midwives, so we don't want to confuse the two, though I know that can be very confusing at times for senators and also for consumers. And so it is, ACNM feels it's quite an injustice to have this restriction in statute, and for those that were part of licensing this bill in the 90s, the expectation was that this would easily be removed, or in the 80s, that this would have been overturned because there's stronger evidence to support having somebody licensed and regulated at a home birth than not. And when you take a group of women with the same demographics and same risk factors and give them to have them deliver in the hospital, have them deliver at home, and the studies that have controlled for those demographics, the outcomes are consistently as good, if not better, because of the reduction in other interventions that are easy for women to say yes to, like epidurals that we know do have some complications with them. So we're surprised this hasn't changed. We're hopeful it will, and that this restriction will be removed. There's still obstacles regarding the written practice agreements. It is wonderful for nurse midwives to practice collaboratively with physicians. From a national level, the American College of Nurse Midwives has been working with ACOG, the American Congress of Obstetricians and Gynecologists, to build better practice relationships. I sat on the ACNM Board of Directors for a term as a regional representative. My term ended last year. We spent a lot of work with them on how do we learn, or how do we work better together so we can ensure safe outcomes. And the ACNM is not supportive of written practice agreements. We know that's been restrictive in states and has prohibited nurse midwives licensure and practice in locations. From a professional standpoint, if I'm going to provide optimal care, then I need to do the work to build a collegial relationship with the physician to earn their respect. And when there's an out-of-hospital birth that I'm attending, to have a written plan to be certain that the clients know the risks associated with wherever they deliver, whether it be a hospital, birth center, or home. And the standard of care for standard of practice for out-of-hospital birth is to have people sign consent forms to be certain that they know the risks associated. Just like when you go into the hospital and you have a baby, even though you show up in labor, we make people sign a consent form about having a baby. And to have an established plan. If something goes wrong, what do we do? Who do we call? How do we get there? ACNM is the professional organization for CNMs. We have guidelines for practice and for home birth to guide the rules and regs process in states and to guide the practice for nurse midwives that are choosing to deliver out of hospital. From a 407 standpoint, I'll end my testimony on behalf of Nebraska ACNM at that point. On my own behalf, I was part of the 407 review that was done in 2006. Of course, there was a 407 review done in 93 and 94 at the direction of this committee. The findings from that were that nurse midwives should be able to attend home births, and nothing was changed. Then when bills came up after that, I remember Senator Erdman that would sit over there and say, was there not already a 407 review on this? Why do we need to do one again? But Senator Johnson insisted on it before a bill came forward again. So another 407 was done, and if Don Wesley's still in the audience, I think it's a great process to review things, but there were limitations with that, and I felt that there was a lot of bias in that process. I'm thankful for the changes. I think it has improved a bit. I don't think this needs to go back to 407. The technical review committee found that nurse midwives should be able to attend home births. When it went through the further steps, the final decision by the state medical officer was to not allow CNMs to attend home births. So I feel like this process has already cost the state twice. At this point, it hasn't been the best academic review that it could have been. I think it would be hasty to go through the process again because it was a lot of work, time-consuming, and money invested in it. And we know that in other states, home birth is being done appropriately by people that are held to standards of practice. There's a couple things that came off the questions that you guys have that if I can speak to them as a nurse midwife who attends out a hospital birth.
Let's stop at that point just to make sure. Let's take the current questions and then we can come back to that, if that's okay. Senator Chris, you
were going to answer the... Go ahead. Finish with...
Were you going to answer?
Well, I do attend birth centers and home births in the state of Texas. I work for a college of nursing as a division in Kearney, but my clinical practice, because I'm not able to practice here, how I'd like to, I practice out of state.
Okay, that's my first question. My second question was, in the 407 process, you felt that the 407 took you to a point which would have allowed for home births by midwives, but that it was a decision of the current chief medical officer made the final decision that was not.
But also the steps are Technical Review Committee, Board of Health. There's a subcommittee and the full Board of Health, and then the state medical officer. For those that were present there, and there's some women in the room that were present there, people would vote and then give support for it, and it wasn't based on the evidence that was presented to them or the research presented. So there were some biases involved there. Darrell Wills chaired the Technical Review Committee and was on the Board of Health, and I believe he submitted a letter to you guys about his...
That is precisely what's different about this 407 process that was not in place. Then my last question is this. You talk about, actually the doctor talked about low risk and being able to have a home. Do you establish a patient transfer agreement with a hospital or the local hospital or a local clinic, or how, if you've been there, done that, worn this t-shirt, so tell me, how would you design it? What will we require to have in place?
This is an interesting topic. Right now in Texas, the Texas Medical Association is trying to implement a requirement to have a written practice agreement with a transfer agreement with the hospital to be willing to accept transfers in order for a birth center or home birth midwife to be licensed. This is a huge obstacle in other states that have implemented this, and it's put businesses out of, nurse midwifery practices out of business. In my practice, we have a consulting physician, so if we have a need for a transfer, we do risk assessments throughout their care before we take them on to care. Throughout their care, definitely at 36 weeks when they're appropriate then to deliver out of hospital, we reassess when they're admitted to care, and then throughout their labor, we're providing assessments. And if at any point there's a need for transfer, we do. Thankfully, most of the transfers are low risk. They're ones that could go into own vehicle. There's not a high cost associated to that. If there are major ones, then we would take an ambulance. But what we end up doing is we consult with the physician and say, here's why I think I need to transfer somebody. They never turn down, when I call, I've never had my consulting physician turn down a transfer because he knows if I call him, it's now not appropriate to stay out of hospital. And the hospital can't turn somebody away. So even if he didn't accept, I could take her to any closest hospital and they would have to treat her.
Which is the last question.
Yeah.
The obstacle in Texas now being provided is it on the hospital end, making it more difficult for a transfer agreement to be put in place, or...
I think it would be the pressures from the medical association. But hopefully this bill doesn't pass. It just got introduced last week.
This one?
No. This bill I'm talking about that would require the transfer agreements with hospitals.
Okay, I'm just kidding.
So I work at a birth center that has over nearly 7,000 births and incredible outcomes. And birth center births, we have births in a birth center here. Outcomes are incredible. There was an article that came out this past month about the outcomes of birth centers. And people don't realize often that we take the same thing to a home that we have in a birth center. There's no difference in what we have for medications or supplies. ACOG is supportive of birth center births attended by nurse midwives. They're still not supportive of home birth. There's a lot of work yet to be done there, but it looks no different. Sometimes we're actually closer to a hospital than we were at the birth center, and then people don't have to drive in labor. So from a supply standpoint and standards of practice, it's consistent. They're the same.
Thank you.
Senator Crawford.
Thank you, Senator Campbell. Now, we discussed the packet of outside testimony when we first sat here, so I've had a chance to read it thoroughly, but it looks like to me that the 2006 review, in that review, they were also wanting to remove the requirement for a practice agreement with a physician. And it's my understanding that in this bill, what you're asking for is, you're not asking for the independent practice. You're asking to provide birth at home, and there would still be a collaborating licensed physician in the mix.
Correct. Those they're two big topics, and it's really warrants more than one committee hearing. The removal of the written practice agreements is something that the Nebraska Action Coalition is working on. There's a 407 review right now for NPs to look at that. I don't think if this line is struck, there's not going to be a huge influx of people providing home births. There's going to be midwives willing to do it, nurse midwives willing to do it, but we're going to have to find a consulting physician to sign our practice agreement so we can be licensed so we can do it. So there's still a huge obstacle. This is just the early steps in getting to that point where it's no longer prohibited, something's allowed. So if we can build those relationships, there is potential for nurse midwives to be able to attend them. So it doesn't solve the problem right now of we're having people attend births at home that are not being screened appropriately, that are being cared for by people that when they're transferred to the hospital, they're not going to submit their documentation, their paperwork, so there's going to be a huge gap in continuity of care. So there's room for improvement, yeah, but this isn't removing the written practice agreement. We'll get there. The recommendations from the National Council of State Boards of Nursing and National Institutes of Health is by 2015 to remove written practice agreements for all advanced practice nurses. I think it's going to be a little bit later in Nebraska for that. I'm hopeful, though, it'll happen by then. But this is, of course, just striking the home birth restriction.
Could you talk a little bit about the assessment of the home or that you would do with someone that you're working with as you're developing your plan for the birth?
So generally, a nurse midwife or any midwife that's going to be attending a home birth usually have at least, if not more, at least one visit at the home to assess not only can we get to it easily, can we find it, if we're going to a hospital, where's the route for that? If we have to call EMS, where do they come from? How long does it take for them to get there? So those are some initial things. Then the other issues, which most people wouldn't think are a big deal, but if you're attending home births on a reservation, or I'm in an area that has colonias, which are a lot like reservations, is the home clean enough? Is there running water? Is there heat? And can we do the things that we do at a birth safely and appropriately? And sometimes there are living conditions where it's not appropriate. The birth center I'm at, the nurse midwife, there were Catholic sisters that founded it. They started to attend home births, then built the birth center because the living conditions weren't appropriate for home birth. And now they've since resumed them. But it's a selective process. So just like risk assessment, some women are not appropriate to stay out of hospital. Likewise, sometimes the living conditions, their home environment isn't appropriate for it. So,
could you talk a little bit about the prenatal and postnatal care that you provide as a
nurse midwifery care, when it comes down to labs that are done and follow-up, it's going to be there's standards of care that are established in the U.S. by the CDC, and a lot of the standards have been established by ACOG, actually, the American Congress of Obese and Gynecologists. So the labs are done at the same time, the same appointment schedule is usually adhered to, follow-up is adhered to as well, postpartumly. The hallmark with midwifery care in the U.S. and across the world tends to be that there's more time allowed for education, to get to know people, to do those early screenings. And unfortunately, in the U.S., our model of care doesn't allow physicians the luxury of having a lot of time. So a lot of the work is done by the nurses regarding some education and time taken. We are seeing improved outcomes with education when time's taken. So the prenatal schedule, exactly the same in clinic, except that visits are longer. New OBs, return OBs are an hour, postpartum visits are an hour, return visits usually half hour. They typically run longer, so we always have extra nurse midwives available to see people where I'm at. And then postpartumly, for a home birth and for a birth center birth, it's traditional to do early home visits, so usually 2 or 3 days, sometimes 1 day, depending on what was going on after delivery and immediate postpartum. And then generally a 2-week postpartum visit at home, or a 10-day. And then generally a baby's seen by whoever the pediatric provider is at 2 weeks. Depending on the state, some insurance companies require by a month, so if they're perfectly healthy and fine, then the nurse midwife will follow them up to the first 28 days in our training and education. So usually we'll follow them up to a month. Medicaid use requires that most states are seen before that month is up to keep them on their plan. And then nurse midwives do provide the traditional follow-up 6 to 8 week postpartum visit.
So you can tell me a little bit about some people who have testified talked about their midwife encouraged them to have a relationship with a physician, so there was some continuity of care. Could you talk about your experience with patients and with a partner on that front?
Depends on how it's working right now. My understanding is that because the midwives aren't licensed and they aren't regulated, they aren't able to build that relationship with the provider themselves. So it's up to the family to build that relationship. And most providers aren't going to turn them away. If they show up at the door, they aren't going to turn them away. And if they do need lab work done, and if their decision is, if the patient's not going to have things done versus that provider being willing to do some of it, then most providers are going to be willing to do some of those lab work and if they need to be transferred. Typically what happens though is that a midwife in most states, like South Dakota is an example for the home birth that's allowed up there, the midwife has to have a plan for transfer. So depending on where she's at, that sometimes would dictate who she consults for delivery-related things, and then it might be a different provider that she would consult for like during birth or during, pregnancy. That may be somebody that she works with a lot. That's going to develop ultrasounds if needed, a higher level ultrasound, or consulting at that time. So there usually is a relationship that's established. Now, it isn't always in writing. When things get in writing, that does increase the risk of vicarious liability, and I can see why a physician would be hesitant to get in that. Vicarious liability to a great degree is considered a myth. That doesn't happen that often, that physicians are held liable for what a provider did before them. They're held responsible for the care that they're providing at the time when they that took over care, accepted care, not for what led up to it. So written practice agreements, there's a lot of thought that it's going to ensure patient safety. It tends to be more of an obstacle to care and for people getting access to care versus ensuring it. But a wise nurse midwife is going to build a relationship so that when they're in a bind, when something comes up, and before it gets to be a big complication, that they're able to consult and transfer appropriately. Otherwise, I don't want to take care of them because my profession relies on me providing optimal care, and the safety of that mom and baby rely on me providing optimal care. So when people are licensed and regulated, they can have those conversations, transfer appropriately, consult without fear that they're going to be totally, out of business after that. So, thank you.
Any other questions? When you go for a home birth, and you've had a lot of experience, I know, in states, and I was looking for somebody who had actually done, I knew you did. What equipment do you take with you at a home birth? What equipment should be there?
We definitely want something to resuscitate a baby if need be, so an ambu bag. We take items to do a UVC line, so the place essentially IV line and their umbilical cord, medications if we need to for resuscitating. There's standards for neonatal resuscitation established by the American Academy of Pediatrics, so all the nurse midwives and all the nurses that we take along with are also required to be certified in that. So if we need to do initial resuscitation, thankfully it doesn't happen that often in populations that have been risked out, because we're getting the cream of the crop, healthy of the healthy, that are staying at home. And those things haven't even, in a lot of states, haven't been even designated in rules and regs. They certainly, the feeling is they shouldn't be in statute because those are things that are hard to overturn. When practice standards change, when research changes, you don't want those in statutes because it's really tough to change those. Rules and regs is a better place, or for professional accountability to be held accountable for that. We take medications in case there's a postpartum hemorrhage, which is one of the huge reasons why maternal health care has improved in the last many years, is because we can treat postpartum hemorrhages with medications now. We take IV supplies. We take an oxygen tank, though we've learned that we gave babies too much oxygen for years, and we don't need to use as much as what we used to, so we're learning things, and even newborn care. So we take everything we'd have at the birth center. Short of what we don't have is we don't have an OR. We don't have a physician that can do a C-section right then, so that's what we don't have. But everything else is the same as what we have in a birth center.
So you've got the baby on a fetal monitor.
Well, continuous fetal monitoring actually is not found to be appropriate it doesn't improve outcomes for low to moderate risk women. The thought was that we would reduce the rate of cerebral palsy when we started doing continuous fetal monitoring in the U.S. And what we found in ACOG is a statement to this effect that actually did not reduce CP rates, actually increased rates of C-sections, vacuum deliveries, and forceps. So what we do for women that are low to moderate risk, we do intermittent fetal monitoring. So we listen to the heart tones intermittently with a handheld Doppler versus a continuous fetal monitor. So
that answers. Yeah. Thank you very much. Any other questions? Thank you very much.
Yes. I know there were some other questions that came up. I'll submit some documentation afterwards. And I have a great little video about the history. If you guys haven't seen it, I'll be certain to get that in an email as well. So, thank you.
Thank you. Our next proponent